Assalamu alaikum student. In this new module of neuroscience, we are going to discuss the scalp and skull injuries and the mechanism of the brain injuries. At the end of the lecture, the student should be able to describe the forensic anatomy of scalp and skull and its injuries of medical legal significance. Classify injuries of head according to the involvement of anatomical structures and condition of the dura mater. And is the factor which influence the resultant effect on skull. Explain the mechanism of production of the fracture of skull with their medico-legal significance. Explain the various types of skull fracture. Enumerate the various theories explaining mechanism and principles of brain or the cerebral injury. Explain common mechanism involved in traumatic brain injury. Explain COUP and CONTRE injuries with example. Among the regional injuries, the head injuries are very common. It commonly results from the road traffic accident, assaults, and fall. When the brain is affected, it is always considered serious injury and never ignored. Such injuries, whenever it comes into the emergency department, always requested for the X-ray because there is sometimes no evidence externally. So it skull is seriously injured without the external evidence. After the head injuries, there is higher incidence of the post-traumatic epilepsy, which occurs within weeks to about 1 year in open head injury. Head injuries are classified into two different ways. When the dura mater is involved, depending upon the dura mater, it may be divided into the open head injury or the closed head injury. When the dura is lacerated or torn, it is classified as open head injury. If the dura is intact, irrespective of the skull fracture, then you may consider it as the closed head injury. Second classification is according to the involvement of the anatomical structures, and depending upon the anatomical structures involved, it may be divided into the scalp injury, facial injuries, skull injuries, brain injuries, injuries to the meninges. A scalp is the outermost covering of the head and is continuous with the skin of the face and has 5 layers extending from outside to inwards. This includes skin, connective tissue, gala epineuritica, loose areolar tissue, and pericranium, also known as periosteum. Many times a scalp injury may be the only clue about a deep-seated fatal trauma, and it can also be of help in establishing the time since injury. This is the soft portion of the tissues of the head, and it forms the first barrier of the impact which widen and lower the peaks of the impact. It also increases the resistance to the skull fractures and extending from the eyebrows anteriorly to the superior neutral line posteriorly and laterally from one temporal bone to the other. Scalp is often damaged in the trauma that causes injury to underlying skull and the brain. In order to understand the injuries from the medical legal point of view, anatomy of the various parts of the scalp is necessary. As I told you in the previous slide, that the scalp consists of the 5 layers. That is basically the first layer is the skin, which is a hair bearing area, a feature which enhances protection and insulation of the area. Second layer is the connective tissue, which is further subdivided into two important layers, that is the fatty layer and the deep membranous layer, containing feeding vessels, and due to the density of this layer or the subcutaneous tissue, inflammation is slight in this area. So in this layer, the inflammatory swelling is slight and the hemorrhage is copious, and this hemorrhage is because of the contraction and the retraction of the arteries is impeded by this kind of tissue. The third layer, gala epineuritica, is a dense fibrous tissue and it absorbs the force of the external trauma. Numerous imaginary veins pierce this layer, and this layer vessels connect the scalp to the intracranial venous circulation. So this layer is very important, containing the numerous imaginary veins which are transferring infection from the scalp to the intracranial venous circulation. Then the loose connective tissue is a very dangerous layer, and it permits collection of the pus and the blood. So it is the area where we have collection of the pus and the blood. Then the third one is the last one is the periosteum or the pericranium. It has importance in providing the nature of the injury. When the periosteum or the pericranium is exposed in an injured person, the nature shifts from the shajja khafifa to the shajja mudiha. This is the diagrammatic representation of the anatomy of the skull. As I told you or described in the previous slide, that it consists of 5 layers. The first is epidermis, then the dermis. This is subcutaneous tissue with the septa, and then the superficial fascia. This one is the superficial fascia, and then the aponeurosis. This layer is the aponeurosis. Then uh, loose connective tissue, layer of the loose connective tissue, and then finally the periosteum. Some important points to remember about the scalp injury are that you must remember that the scalp injury may or may not be associated with the fracture of the skull or injury to the intracranial contents. The common injuries are contusion and laceration as a result of blunt impact. The black eye, again a common feature as a result of the gravitational flow of the blood to accumulate around the eye, because the tissue around the eye are loose and the blood gravitate down to the loose tissue. A lacerated wound over the scalp generally simulate incised wound, and this is the feature which causes the special examination with the magnifying glass to differentiate it from the incised wound. So this lacerated wound or the silhouette lacerated wound over the scalp are sometimes known as the incise-like wound. Whenever the scalp injuries are present, there is a chance that the victim may be predisposed to the intracranial infection. The common scalp injuries include scalp abrasion, scalp bruises, and scalp laceration. Important feature about the scalp abrasion that the brush abrasion are less common, and similarly the pattern effect is also less, and these effects are basically due to the presence of the hair protecting the scalp. And whenever the scalp abrasion are suspected, a shaving of the scalp is required, and this is important to visualize the lesser degree of abrasion, otherwise you will miss the abrasion. Then the scalp bruises are in the scalp bruises we have two important injury, that is the black eye and the spectacle hematoma. And black eye is an ectopic contusion or the periorbital hematoma due to the bleeding in the soft tissue around the eye owing to the blunt impact of the forehead rupturing the blood vessel, and the blood tracks down or tracks along the facial attachment around the lower margin of the orbit. In the spectacle hematoma, blood collects in the soft tissue around the eyes due to the fracture of the base of the skull and skull in the anterior cranial fossa fracture. Then the scalp laceration are usually basically the split laceration, and as I told you in the previous slide that the magnifying lens examination is required to see the tissue bridging to rule out the incised wound. In this slide, we are showing you the pictures of the spectacle hematoma. This is basically the picture of the spectacle hematoma, and the second is the black eye. Spectacle hematoma results from the fracture of the anterior fossa or the base of the skull, and the black eye is resulting from the blunt impact from the forehead. Medical legal importance of scalp injury basically consists of It gives a clue about the deep-seated fatal trauma. Sometimes the superficial injury is present, but inside it may predispose to the skull or brain injury. It helps in establishing the time since injury. Extensive bleeding in the scalp laceration occur particularly in the intoxicated individuals. Rarely, if ever, become infected due to the rich blood supply of the scalp, and transfer of the infection can occur through imaginary veins into the superior sagittal sinus and rarely into the cavernous sinus. After the scalp, we are proceeding towards the skull and its injuries. Let's start the forensic anatomy of the skull. Uh, Skull is a diploid bone, and it has two layers: outer, which is thicker and stronger table, and inner, thinner and weaker table. And in between the two plate is the dipole, often marrow containing spongy cancellous bone, which lies within the flat bone. It gives elasticity to the bone. It starts forming at 4 years of age. Before this, it is thin, compact and elastic bone, interrupted at sutures and vanishes where the bone is thin, for example, the floor of the skull. The strongest parts of the skull are greater wing of the sphenoid, petrous temporal, sagittal ridge, occipital protuberance and glabella. The thin portion or the areas are parieto-temporal, lateral frontal and lateral occipital zones. Temporal bone is the thinnest, approximately 4 mm in thickness, and occipital bone is thickest with more than or equal to 15 mm thickness in midline. This is a slide showing the picture of the anatomy of the skull, and you may see that it consists of the three layers. That is the first one, the outer layer, then in between the two layers is the dipole or spongy layer, and the inner one is the uh, inner table. So in between the two inner and outer table is the dipole or the spongy layer. Injury to the skull primarily consists of fracture, which depend upon certain factors. Though it is a strong structure, if the violence is applied, certain factors are important in determination of the type and the character of the resultant effect. And the effect, is basically the fracture. So these factors, which are important in determination of the type and character of the resultant effect, violence acting or the force of active blows or the passive impact, site of the injury on the skull, and then the age of the victim. So we will discuss one by one. So the first factor is the violence acting or the force acting or the energy which is acting on the skull, and it is basically driven by the beat, that is mass, and the velocity, and it is the blow which is given to the skull is converted into the energy. So this energy is basically the kinetic energy. So amount of the energy a blow can transmit is calculated by this formula, that is K is equal to mv square upon 2g. This is the formula which is utilized in calculating the amount of energy, uh, where m is the mass and v is the velocity and g is the gravitational or acceleration, gravitational force or the gravitational acceleration. So you may see that these are the two important factors, that is the mass and velocity, which is describing how much amount is transferred to the skull. So we take the example of iron bar and bullet. Thus a bullet, although a low weight, when fired from a firearm at speed, it is more effective in terms of damage production due to the high velocity with which it moves than an iron bar, which is effective due to its weight. Though heavy, cannot meet to move with the same high velocity as bullet. Violence could be direct or indirect. In the direct violence, the forces acting directly on the bone and produce a fracture. While in case of the indirect violence, the force is acting on the skull indirectly through some other structure which receives the primary impact. That is fall on the buttock of feet from a height, blast explosion, and heavy blows on the chin. Second factor, that is the age of the victim. The skull is more elastic in infants and children, hence it is less prone to fracture. However, the brain tissue being softer in them, it is more highly vulnerable to injury. While in case of the adults, you see that the bones are less elastic and compliant in adults, hence they are more prone to fracture. Fracture tend to absorb quite an amount of the energy of the blow and thus spare the energy going into the brain, which is thus sparing the injury. Third factor, which I have not described in the slide, is the site of injury on the skull. The fracture of the skull could be seen on the outer or the inner table alone or in combination. In both the table, initially due to the bone elasticity, only the outer table undergoes bending. Further increase in the force results in fracture of the inner table first, which is weaker, followed by outer table ultimately. Now coming to the mechanism of the skull fracture, the injury, we have the Row-Botham hypothesis, which states that the fracture can occur as a result of direct application of the force to the skull, for example, blow over the head with the iron rod. Then the second mechanism is the indirect violence, that is fall from the height on feet or the buttock. Then the direct force fracture may result from the fracture due to local deformation and the fracture due to the general deformation. In case of the fracture due to the local deformation, the mechanism is that when the focal force is applied to the moment, a distortion of the shape of the skull occurs. That is, the area under the point of impact bend inwards, and incompressibility and inward bend of the skull causes compensatory bulging of the other area, which is known as stuck hoop analogy. So if the acting force exceeds the elasticity of the skull, inward and outward band get fractured. In severe impact, depressed fracture occur and shape of the impacting object is formed. According to the fracture due to the general deformation, as per hypothesis, the skull behaves like an elastic sphere. If the skull compresses in one plane, it bulges in other direction. For example, in compressed laterally causes increased vertical and longitudinal diameters and fracture of the skull at these points. Then similarly, the fracture occurs when the head compresses between the two external objects, results in the fissure type fracture and occurs removed from the point of application of the force. This is the diagrammatic representation of the local force acting on the bone. That is, when the force is applied on the outer table, it gets inward and then the bulging occurs at the inner table. So when the force exceeds the elasticity of the bone, the fracture of the inner table occur first and then the outer table. In picture you may see that the general effect of the force is seen. That is, when the force is applied on either side, the head bulges in the vertical direction, and when the force is applied from above, it bulges in the horizontal way. and that is why again you may see in the last ad where the force is applied, it causes inner table fracture on the side of impact, and then the bend on the bending side on the outer table, and if the force exceeds the elasticity of the bone, the fracture of this sides occur. Skull fracture may also occur as a result of the indirect violence, and due to this indirect violence, the vault or the base of the skull is fractured. In this particular type of fracture, the causative force applied is away and it is transmitted to the skull. There are three different types of the fracture produced as a result of the indirect violence. That is, when the force is applied to the chin, the fracture of the glenoid fossa occurs. When the force applied below the mandible, the cribriform plate is fractured and the force is transmitted through the maxilla to the base of the skull to produce cribriform plate fracture. The third one, that is when the force is applied to feet or buttock, force is transmitted upward through the spinal column and it produces ring fracture. PUPPE'S rule. In cases of multiple blunt force injury to the skull, analysis of the skull fracture using the PUPPE'S rule, it may provide evidence on the sequence in which the injuries occurred. So the importance of the PUPPE'S rule is basically that it determines the sequence of events of the application of blunt forces to the skull. When two or more separate fractures occur from successive impacts and meet each other, the latter fracture will terminate, not crossing the first lecture in. You may say that the first lecture will end at the second fracture will terminate at the first fracture. The termination of the second fracture will interrupt the cranial distortion which precedes fracturing. So it is important by this way, or it is possible by the application of the PUPPE'S rule to determine the sequence of events of application of blunt forces, or you may describe which fracture is the first or which one is second. Now, what are the different types of the skull fractures? So, skull fractures may be divided into the fracture of the vault of the skull, and second category is the fracture of the base of the skull. We will discuss separately the two types of the fractures. Fracture of the vault of the skull include fissure fracture, depressed fracture, comminuted fracture, stellate fracture, mosaic fracture, elevated fracture, dystactic fracture or the suture line fracture, gutter fracture, perforating fracture, pond fracture, which is basically the indented fracture, cut fracture, and then combination of any of these different variety. Now the first fracture is basically the fissure fracture, and this fissure fracture is indicated on this X-ray, that is the arrow indicate this is the fissure fracture. So a linear or the fracture, fissure fracture is basically a linear or crack fracture involving only the outer of the inner table or both table simultaneously, more common in the inner table and frequently missed on X-ray. So this is the fracture which is usually misinterpreted or not seen, usually missed by the practitioner on the radiograph. Three types are usually seen in the fissure fracture, that is basically the COUP fissure fracture, CONTRE fissure fracture, and the third one is the bursting fissure fracture. Depress or the signature fracture, it is seen again on the X-ray. You may see that this is basically the fracture that is depressed, and it is also known as signature fracture. So the fractured bone fragment is driven inward for some distance below the rest of the adjacent skull contour, and it corresponds to the size and shape of the causative weapon and therefore give clue about the weapon. Generally, those weapons which are heavy and having a small striking surface produce such type of the fracture, that is the depressed or the signature fracture. Common example of the weapon is the hammer. Comminuted fracture is a type of the fracture in which the bone is broken into different pieces, and It is not a single fracture. It is usually associated with two or more fractures. So in this picture, you may see that the bone is broken into different pieces. So bone is broken into several pieces of different sizes, and it is usually occurring as a complication of depressed fracture. The common causes of this type of fracture are basically the vehicular accident, fall from the height, skull receiving blows from a weapon with a large striking surface. For example, the iron bar, that is opposite to the depressed fracture. This later the radiating fractures. This is an example of the comminuted fracture. A comminuted fracture with the fissured fracture fragments which are radiating from it and held intact. Causes are similar to the comminuted fracture. Mosaic or the spiderweb fracture. It is a non-depressed comminuted fracture where the fracture site appears in the form of several fissures taking the form of a spider web or COUP web or mosaic pattern. So it is just like a spider web. In elevated fracture, one end of the fracture fragment is elevated above the surface of the skull, while the other end may dip down into the cranial cavity, and this may result into the damage to the dura mater of the brain. Usually, this type of the fracture results from the blow with the heavy weapon, just like the axe, which causes this fracture. Diastatic fracture or the suture line fracture are basically fractures occurring along the skull suture and commonly seen in children and young person. You may see in the picture this type of the fracture shown as in this case. You may see that this is the circle which is representing this is the diastatic fracture, and it is basically seen along the line of suture. And then in this figure you may also see that the separation of the suture takes place, which is again an example of the diastatic fracture. Gutter fracture. In this type of the fracture, thickness of the skull bone, that is some portion of the thickness of the bone is removed, forming a gutter or the furrow in the bone. And it usually occurs when the weapon strikes the skull tangentially. For example, it is seen in case of the glancing bullet injury. In perforating or the whole fractures, the total thickness of the skull is affected, leading to an irregular depressed fracture of both the inner and the outer table. Here the skull is perforated by the sharp pointed object or the weapon or the bullet, and the size corresponds to the dimensions of the offending agent or the weapon. Wound or the indented fracture, this is simply seen as a simple dent in the skull, and it commonly occurs in the infants, and due to the pliability of the infant bone, force produces depression without fracture. It commonly results from the obstetric forceps blade, that is the application of the obstetric forceps blade, or a blow from the blunt object or forcible impact against some protruding object. Cut fracture are seen as straight chops of the skull resulting from the blow with the heavy cutting weapon like the axe or the sword. It involves either the outer table alone or sometimes affecting the board table. In combined fracture, there is combination of more than one of the described fracture. Fracture of the base of the skull are divided into 6 different types of fractures, and 3 of them are basically belonging to the cranial fossa, that is the fracture of the anterior cranial fossa, middle cranial fossa, posterior cranial fossa. Then the fracture around the foramen magnum, which is also known as ring fracture, then the hinge or the motorcyclist fracture, and finally the longitudinal fracture of the base of the skull. Fracture of the anterior cranial fossa result from the direct impact or contour coup injuries, and it manifests as the black eye or escape of the CSF or blood from the nose. Then the fracture of the middle cranial fossa result from the direct impact behind ear or crush injuries of the head, and it manifests as the escape of the CSF around CSF and blood from the ear. You may see in this picture the fracture of the middle cranial fossa. Then the fracture of the posterior cranial fossa results from the impact on the back of the head, and it manifests as the escape of the CSF and blood into the tissues of the back of the neck. So here you may see basically the fracture of posterior cranial fossa. Then the fracture around the foramen magnum, it is seen around the foramen magnum, approximately 5 centimeter outside the foramen magnum at the back, middle ear on either side, and roof of the nose anteriorly. And it commonly results from the fall from the head while landing on feet or better. A sudden violent turn of the head on its spine, or heavy blow on the chin or occiput. Then the hinge or the motorcyclist fracture, it is a linear type of fracture which passes across the floor of the middle cranial fossa, often following the patellar temporal or the greater wing of the sphenoid bone into the pituitary fossa on both sides. This type of the fracture is basically separating the cranial fossa into two different halves, the anterior and the posterior. Longitudinal fracture of the base of the skull encountered in 75% of all basilar skull fracture, and it occurs parallel to the petrous temporal bone. There are various theories which explains the mechanism and principles of the brain or the cerebral injury. Out of this, the two important theories are the linear acceleration theory and the Hall-Brun hypothesis. Linear cerebral theory was first published about a century ago, and according to this theory, relative movements and the secondary impact occur between the skull and the brain during a head impact. The pressure increases in the superficial cerebral structures below the impact zone, which is proportional to the head linear acceleration. This theory is basically explaining the occurrence of most of the superficial cerebral lesions. Then the second, the Hall-Brun hypothesis, was proposed in 1943. According to this theory, the rotational moment or shear strain is the basic principle which is producing the brain damage. Accordingly, the traumatic brain injury, especially the deep cerebral trauma, are caused by tensile strains occurring between the superficial and the deep cerebral structure during the circular head movement. So generally, it is basically explaining the deep cerebral trauma caused by tensile strains, and the spatial distribution of the pressure gradient is responsible for tissue strain, cerebral lesion localization, and neurological signs. Common mechanism involved in the traumatic brain injury are acceleration injury, deceleration injury, shear strain or the rotational injury, COUP and CONTRE injury. These are the four different mechanisms which operate in producing the brain. When a moving object hits the head, which is static, the skull picks up the momentum first and hits the brain, which is still in rest, and it is yet to pick up the momentum. This is called acceleration or the accelerating injury. For example, a blow on the head with a hockey stick leading to brain injury is an example of acceleration injury. In the accelerating injury, the head picks up the momentum after a strike from an object, while in the deceleration injury, the moving head is decelerated or become static after rest from a static object. So when a non-moving object suddenly arrests the head in motion, the skull loses its momentum much prior to the brain, which hits the inner aspect of the skull before becoming static. This is called decelerating injury. Example of such injury are that, for example, a person riding in a scooter sustained head-on collision with an electric pole leading to brain injury. Shear strain or the rotational injury is due to the side-to-side movement of the head, which makes the brain get jolted on the sharp edges of the tentorial attachment in the interior of the skull, and in this way it is injured accordingly. COUP and contra-COUP injury. This type of injuries are seen in head and chest. In case of the COUP injury, the injuries are immediately adjacent to the area of impact when the head is fixed. So the provision is that the head should be fixed and it is just immediately adjacent to the area of impact. And the principle of the COUP injury is that the smaller the area of impact, the greater is the likelihood of COUP injury. It results in contusion and hemorrhages at the site of impact. Example, if a person is lying on the ground while in impact, over the occiput will produce or cause fracture and damage to the brain, which is beneath the site of the impact. This is the COUP injury. In case of the contra-COUP injury, where the injury to the skull and the brain occurs on the opposite side of the impact, that is, it is situated on the contralateral side of the area of impact. It is commonly seen in the road traffic accidents and falls, and occurs when moving head suddenly decelerates by hitting a hard surface, and it occurs only when the head is free to move. Example, a person falls upon the back of his head striking the ground with the occiput. He may sustain injury at the occipital lobe, which is COUP injury, and more pronounced injury to the frontal lobe, which is known as contra-COUP injury. This picture is showing the close head injury in which the COUP and the contra-COUP injuries are shown. Now you may see in these two different types of the picture, A and B, that is taken from the example of a driver which strikes his head with the steering wheel. So in picture A, that is the contra-COUP injury is shown to the brain, which occurs when the brain strikes the skull on the opposite side of the impact. The side of the impact is this one, and this is the opposite side. So the contra-COUP injury to the brain occurs when the brain strikes the skull on the opposite side of the impact. Once the skull has stopped moving forward, the brain continues to move backwards, striking the back of the skull. In picture B, the COUP injury to the brain occurs, that is the COUP injury, when the brain strikes the skull on the side of the impact. So this is the side of the impact which strikes to the steering wheel, as taken from this picture. It is the striking surface. So here the COUP injury is produced. The question arises, what is the medico-legal significance of the COUP and the contra-COUP injury? So you may see that in case of the blow, brain shows much larger contusion underlying the area of the impact, that is on the side of the COUP injury, than on the opposite side to the impact. While in case of the fall, head injury resulting from the fall, the contra-COUP injuries are located in inaccessible portion are larger than the COUP contusion. So we can make a conclusion about the injury that either it is resulting from the fall or the blow on the basis of localization of the craniocerebral injury. So in summary, for the mechanism and the principles of cerebral injury, we have certain points to remember. The first one, the injury to the brain can occur even without the injury to the skull. Rotational strains, that is the torsion, tearing, angular or shearing strains, are predominant, pulling the constituent particles of the brain apart. Then the third important point, the harmful effect is increased when the brain movement is prevented by the bony prominences of anterior and the middle cranial fossa. Changes in the rate of the movement are of great importance in producing brain damage. Cerebellum is smaller than the cerebral hemisphere and therefore escapes damage by rotational strain.